Okay. I'm Teddy Hart. I'm one of the vascular surgeons. I was asked to talk about PAD today. So this topic or this, quick lecture, I think is probably targeted mostly at junior trainees, people that are getting the bulk of calls. It's grown out of this, I don't know, general sense that we get a lot of dumb pages and dumb questions, and you kind of just wonder whether like the fundamental understanding of the disease that's being called about is there. So this is to make sure that, like on our end, well, I'm very serious, like that, like we truly are thinking about these things in the correct framework, that we know, definitions and terminology such that, when you guys get called about them, you sound, smarter when talking to a consultant, smarter when presenting a patient to us, and then that hopefully have a little bit of a framework to think about, the decision making that's going on. So there's not a ton of surgery or procedural stuff in here. It's a little bit more again on just like a thinking plane. So I guess just approach it in that way. And again, right, this is an hour, and then this is something that spent years training in. You could break down a lot of different things into hour-long topics. So to the extent that stuff is, seemingly glossed over, it's, mostly intentional to try to, get through what I wanted to get across. So first, this is one of my favorite cartoons. I shared this cartoon at a lecture last year, but not everybody was here. So, okay, so objectives. So again, terminology based, and then there's a little bit of literature and some, I think good frameworks for more senior trainees and stuff who are interested. And then, yeah, I think in the end, right, you want to be able to recognize and then direct some appropriate management for PAD, whether you encounter it, in the clinic as a consulting service, from various angles. And then finally, a little bit about the operating room side. Okay, so one of my favorite phrases, and the chiefs have probably heard me throw it out or whatever when you're calling for consults, is acute recognition of chronic disease. And this happens, a lot. And again, this is kind of what motivates a lot of stuff in this talk. So it's a good, this is never in a textbook, but a way to understand and know kind of what you're talking about is sometimes framing somebody else's recognition and consult and with, urgency about something that's very chronic. That's how I describe it. So the dashed line here really separates assessment from plan. So, essentially we're going to talk about, understanding chronicity. So whether something's acute on chronic, or chronic, and then categorizing it appropriately into its clinical categories. So whether that's acute limb ischemia, or then for chronic limb ischemia, whether somebody is asymptomatic and they're just calling you, whether they're claudican, or whether they have critical limb ischemia, which includes rest pain and tissue loss. And then in terms of tissue loss, whether they have arterial tissue loss, venous, or mixed picture. So that's the assessment half of things. And then the plan, right, is, a little bit toward what the relevant workup for these patients are in various scenarios. A bit about medical management, because medical management, as part of the talk I'll center on, is, actually extremely important for this disease. And then lastly, to touch on operative management. So, okay, so I like to say that the chronicity here is what kind of dictates the management. So, when seeing these patients, right, if you get the consult and you're the first person that's there, trying to fill out the information, I think the important things are really to figure out, well, why is this person here now? And then, what setting are they in and why? And you have to try to make sense of it, because some of these people have goofy, reasons for being there that don't necessarily link up to the, limb complaint. And I think getting to the bottom of whether something is truly different, whether their wounds have gotten worse over time, whether, perhaps they just haven't been able to access care, and they have finally, at the urging of a family member or something, decided to access care that day, that afternoon, that middle of the night. Or if they're there for a completely different complaint, and they just, again, they're making rounds and the team notices, hey, we noticed something is on, this other leg, and we got a CT scan and we saw this, and, can you help us? And they're there, again, for a completely different, complaint that's related to, who knows, electrolyte imbalance or something, right, on the medical service. So, and then, the important thing here, though, and when you're seeing these people, and it's not to dismiss it, it's that what you're really trying to rule out every time is whether somebody has acute limb ischemia or some sort of acute on chronic presentation, worsening of chronic disease, that actually requires urgent management, right? And this is what we, colloquially call a cold leg, but in essence, people can have chronically cold legs, right? So, and the way that you really drill down and see whether somebody has acute limb ischemia or an acute change that really needs attention, right, is the sensory motor exam for these patients. So, and in particular, I think understanding what the other leg looks like as a starting place. So often if I get called about a cold leg, or that's the consult, I'll purposefully start with the other leg, focus on the other leg for the first bit of time to know, like, okay, well, this should be the normal baseline. And then what's the other leg like in comparison, right? And, you guys do this regularly, but obviously their pulse exam or their Doppler exam is kind of important, and being able to compare those is important. And on the sensory motor exam, I think you guys have probably heard this at one point or another, the most, does anybody know the most sensitive spot for sensory changes to check for? Bueller? I think I heard it. Yeah, between the web space and the between the first digits or whatever. So I think really, having a very kind of detailed, exam, in particular, checking that space for changes is important. I wanted to put this up here. This is actually a nice slide that's in the presentation that the medical students get of a patient with an acutely cold leg and kind of what it will look like. So you kind of have a sense for the leg has a little bit more, essentially like rubor to it, and then has this very delayed, cap refill that's present, that's being shown here. So this is often, the exam of somebody with an acute change, or, terrible rest pain that's gonna, be enough for them to present. Okay, so then kind of for the senior level trainees, in terms of talking about, classifications and how to frame things, right? I've heard you guys use it before, but we use the Rutherford classification. So the Rutherford classification for acute limb ischemia basically has class 1, 2, and 3, and then 2 is broken down into 2A and 2B. And the way I always remember it is that 2A is sensory impairment, 2B is motor impairment, and then 3 is just a non-salvageable extremity. And again, the reason this matters, right, the reason why this assessment, is important is because it then dictates the exact management for this disease process, right? So people have class 1, limb ischemia, where their limb is not threatened. The question you have to ask yourself is, do they need treatment at all? And then, if so, why, how, and on what timing, because there's, again, no immediate limb threat. So class 2A, though, if it's only sensory changes, this is something that, ideally you might be able to work on during the daytime. And that you typically have time to do anticoagulation. Often thrombolytics are an option, depending on, again, what other, milieu the patient is in. 2B, though, is going to need, obviously, immediate revascularization, to address, honestly, what is a very threatened situation, somebody that's ischemic to the point of a motor change. And then those operations often tend toward, definitive upfront management of it. And you have to be prepared, to do, a number of things. So, and then class 3, right? So if somebody's leg is dead, the treatment for that is never to revascularize. The only reason those people get revascularization is if you're worried about them being able to heal the primary amputation that they need for the ischemia, right? So if somebody comes in, they have a dead leg due to, an embolus, but the embolus is still there at the femoral artery, probably in order to heal their amputation, they're going to need, that thrombus or that embolus removed. So the reason those things get paired sometimes is really more toward, again, amputation healing, or, that sort of thing. But primary amputation is the treatment for somebody, again, with a completely non-viable leg. And, you know, the other reason, not that I've seen it before or anything, is, you know, if you do revascularize those people, they have terrible reperfusion, right? So they will get very systemically sick, you know, from the washout of all the lactate, all the potassium, et cetera. You know, and that in and of itself can be a lethal event. So it's important then, you know, again, to classify these people. And the reason why, right, is it dictates the management. And this is actually a very clean example of that in vascular surgery in my mind, and one that, you know, I think everybody can be, you know, again, responsible for and knowledgeable about. And then really, this is the do not miss diagnosis, right? This is the, you know, they call you about something that sounds chronic, and you want to make sure that this does not exist in the milieu, because you assume, right, that whoever is calling you might not know what they're talking about. Okay, but it often isn't acute, right? These are terrible pictures of people's foot wounds or whatever. I did want to put this first one up because the first one on the left is a venous wound, okay? And I had mentioned venous early in the talk. So sometimes with people that have arterial disease also have venous disease. And in part, they might develop a venous wound, right? Which is at the level, you know, of the ankle or shin, is often in the setting of swelling and breakdown of the skin just due to tension and chronic damage there. And the way these wounds get healed is actually with compression, or being able to squeeze out the fluid such that the body can scar over and epithelialize over these things. But in people that have bad PAD or arterial disease, they might not be able to tolerate the squeeze necessary to heal this wound. And then in essence, if you tried to do that therapy, you would cause, you know, more necrosis just from the compression and that sort of stuff. So, you know, people with PAD can have venous wounds. And actually, in my view, those are kind of the hardest ones to treat because it's, again, typically multiple pathologies that are present. So there's also a classification scheme for chronic. And while everybody is typically pretty good about trying to maybe break down the acute limb ischemia, very rarely does somebody say somebody has Rutherford 5, you know, critical limb ischemia or whatever. But these do exist. There's different grades and different classifications. But, you know, the reason I more or less like this is because there's a little bit of a continuum here that's presented, right, with the worst being, you know, again, major tissue loss, and starting at people that just have very mild claudication. But the easier breakdown, you know, that I think is worth having is just being able to classify people into people that are either asymptomatic or have claudication, and then people that have critical limb ischemia. And as the presentation goes on, I'm going to go into why those things are, you know, extremely different. But, you know, when you've ruled out something acute and you're continuing to talk about whatever it is, the next thing that I'm often listening for is, you know, what's the clinical entity that we're dealing with? And in chronic limb ischemia, they're either, you know, again, claudicants or asymptomatically found, or they have, you know, again, critical limb ischemia. So just for context, asymptomatic, right? This is like, you know, they call you because somebody has a plaque on a CT scan, or there's a slightly abnormal ABI that was ordered for some reason, but the person tells you they have no symptoms, they can walk fine, they run marathons, you know, whatever it is. You know, then people who have claudication, I think you guys have all heard this term, and it's a very classic one, right? It's, you know, classically calf or buttock cramping. It's very reproducible and dependent on the extent of activity or exercise. But there's other things that mimic it. People that have back pain, you know, can have kind of very similar presentations, and sorting that out is often something that, you know, we're left to do in clinic kind of based on studies and history. Interestingly, the one tip, and it's not up here in the slides, but that I like to ask people to differentiate neurogenic claudication from, you know, arterial-based claudication is actually if you ask them about their shopping experience at the grocery store. And the reason this is, right, is if people hunch over on the shopping cart, it changes the position of their back such that it relaxes the space and allows the nerves a little bit more breathing room, and they can walk around the store okay without having pain. But when they're, you know, I guess upright, not shopping or whatever, they're in terrible pain. Okay, and then claudication is often, you know, centered around in the decision-making, whether it impacts lifestyle. So is that keeping somebody from working? The classic one on the test, right, is the letter carrier who can't complete their mail route, you know, because their calves hurt too much. And then, you know, in gathering a history, right, you often focus on what's the time to their onset of symptoms? How long can they go? Can they do inclines, those sort of things to fill in, and really capture and describe the details. Okay, so that's claudication, asymptomatic disease. So the separate entity then, critical limb ischemia or chronic limb threatening ischemia, is people that have rest pain or tissue loss, right? And rest pain is often a dependent pain where somebody, and it's classically at night when they're laying in bed, they have so little flow to their leg that their leg will throb, typically in the foot, and they have to dangle the foot off the bed in order for it to fill by gravity with blood to get some relief of the symptoms. These are often people that have very low ankle pressures, right? So the studies on these people are often an ankle pressure that, again, is normally at or slightly above, the normal brachial pressure. So it's normally 120, 130. In these patients is often 30 or 40. And then in particular, if you measure the flow in the toes, it's often either undetectable or a toe pressure that's less than 30. It's, very, very low. And then on exam, right, their exam will kind of look like the acute limb exam, except they'll just give you a different clinical history. And then tissue loss, right? So tissue loss, I think just in characterizing it, and we're going to go into a lot of stuff about critical limb ischemia in the end, but just in terms of characterizing it, does the person have primary arterial ulcers, which are kind of more akin to the second and third pictures on this page? Do they have, again, venous ulcers? Is it a mixed picture? And then, people also have wounds for other reasons. Do they have an amputation wound that they aren't healing from orthopedics? Do they have a trauma wound, a pressure wound, some sort of diabetic foot wound mixed with arterial disease, those sorts of things. So recognizing that this comes in different, kind of flavors, and being able to, again, describe exactly where it comes from, just, again, helps to paint the picture of exactly, what we're working with, because that then, again, dictates what the goals of therapy are and what the kind of bigger picture is going to be for that patient. Okay, so stopping just for a brief review at this point. So again, the critical stuff in the assessment, right, is basically being able to name the problem, really taking a look at the chronicity, because it's going to dictate the urgency of the management for any given patient. Again, the acute limb or the acute on chronic limb is a do not miss diagnosis. And then after determining the chronicity, you want to define the severity. So if it's acute limb ischemia, right, you're going to try to give it a Rutherford classification. If it's chronic limb ischemia, you're going to say whether that person has claudication or critical limb threatening ischemia. All right, so next I'm going to jump into workup and management, starting with claudication and then ending with critical limb ischemia. So claudication is actually where a whole bunch of medical stuff comes into play. So just a few facts about claudication that I think are underappreciated. Number one being, these patients really are not at great risk for any amputation or limb loss. And I think that's like one of the biggest misnomers in, like general medical education, or just kind of what's out there. But the numbers actually support that they probably have a 1% risk per year risk of major amputation. And only about 1/5 of those patients, if you follow a lot of claudication patients in the literature, only about 1/5 are going to have progression of disease or need for any intervention revascularization. However, the thing that is striking is these patients have extremely high mortality, to the tune of over 10% per year. And it's about, a 50-50 chance in 5 years that they're going to have some sort of major cardiovascular event, heart attack, stroke, that sort of thing. And then, if you just, kind of want context or want to parallel it to something, there's papers out there that support these numbers, these cardiovascular outcome numbers are similar to patients that have had a heart attack. So I would think of it as, if you're seeing some patient with claudication that has that risk factor, they're kind of in the same risk bucket as somebody who just had, an MI. It's like a very serious, very morbid diagnosis. So actually, the most important thing for them, right, because they're not at immediate risk of limb loss, and they're really at very low risk, chronically for limb loss, is to try to modify any risk factors, in their cardiovascular disease profile. And the way that's done, right, is smoking cessation, control of comorbidities, namely hypertension, diabetes, to encourage them actually to exercise and be active. That's good for a number of reasons, but actually will help their claudication or their index complaint if they're able to do that and adhere to that. And then on the medicine side, there's good long-standing evidence for antiplatelet and statin therapies. I'm going to talk a little bit about new evidence that's there for actually adding Xarelto to people's medical regimens. And then cilostazol can help with symptom relief, but not with really risk factor modification or disease progression or anything. It's basically just a vasodilator that can help them potentially walk a little bit more and augment their exercise. Cilostazol in particular is bad for people with heart failure, and can often cause side effects like bad headaches and things. So it's not always tolerated, but some people do kind of swear by it. Okay, so then I wanted to put these up just to put home the point about essentially how this is a marker of bad systemic disease, or how the mortality is high. So you can't see the graph well, but essentially the top lines are amputations in claudicants, and the one slightly below that is revascularization in claudicants. And this is basically a study that took nearly 3,000 patients from the VA. They took, I think, like 2,700 patients from the VA. They followed them over 15 years and basically just published outcome results on them as a cohort. And again, the risk of, and this is where these amputation numbers are extrapolated from. So low amputation risk, about 1% per year, but this is the mortality curve, where it's like truly about half of these patients, in the course of 5 years, have a mortality event. So I think just being very mindful, right, that when you're seeing somebody with claudication, this is actually their bigger problem than their limb pain often. And you can help them with their limb pain, but you would be missing something if you didn't have this in the back of your mind, that again, the real thing here is not their, not limb loss or amputation risk, but again, cardiovascular related mortality. Okay, so getting into the contemporary data, this is more for senior residents and chiefly residents and everything. So there's a few trials that have come out probably within the course of your training arc that are new, that are, I think, going to impact practice in the long term, and are starting to percolate their way into doing things. And if I'm being honest, it would be like one of my New Year's resolutions to try to get better about matching people into these things. But there were two main trials, the Compass trial and the Voyager trial, both that were studying a reduced dose of Xarelto in combination with aspirin, against other arms, either of higher doses of Xarelto or of, placebo against, the addition of Xarelto with aspirin, and basically looking for adverse cardiovascular outcomes and adverse limb outcomes within patients. The one main one is called the Compass trial. So this is a medical trial. This included, patients with cardiovascular risk factors, and was very high in number. There's a subset trial within that, or a subset analysis within that, where they capture, the over 6,000 patients that have PAD within the Compass trial enrollment. And in those patients, specifically looking, again, at the outcomes between the patients who got the low dose Xarelto twice a day versus not. And they had, improved outcomes with respect to reducing major adverse limb events. The number needed to treat in that trial was actually like relatively, I don't know how you look at it. I mean, it's about like 75 or so, or 76, I think. So, the issue being, you do have to capture a lot of patients, I think, to prevent one bad, event just in regular medical patients. But the bleeding outcomes actually were very similar between, both groups. So it is kind of increasingly a recommendation for patients that just have asymptomatic PAD and want to be optimally medically managed, could consider doing this. The Voyager trial is a trial that used the same medical regimen, but it was in patients that actually had revascularization. So people that had PAD and had some sort of revascularization treatment after. And this similarly captured, somewhere in the 6,000, 6,500 patients that were post-revascularization, showed no major difference in kind of major bleeding events, had a slight increase in minor bleeding events in patients that got Xarelto, but had a significant benefit for cardiovascular death, stroke, and MI, as well as amputation. And the number needed to treat was about half of the larger medical trial. So just kind of, food for thought. We often default to doing dual antiplatelet therapy because of evidence that exists for, drug-coated ballooning, drug-coated stenting that's always done with dual antiplatelet as part of the protocol. But probably in the long term, after whatever short-term, indication is there for that, they should probably be switched over to this just as their chronic regimen. That's what I would take away. And again, these are, kind of the graphs showing the separation in COMPASS trial patients between the two groups. And then similarly, the Voyager trial between the two groups. So, okay, so I said I was going to go into a little bit of workup for these patients and just means of thinking about that. Oh, yeah. So, yeah, this is the composite outcome one. There's one specific, this was, I think, purely the amputation outcome or whatever. It's from the COMPASS trial when they zeroed in on, limb events between the two. And in particular, I think this graph was actually more highlighting the people who had the graph, particularly on the left, where there's a difference in the bars, is actually more or less highlighting something to me that's very common sense, which is that people who have an adverse limb event somewhere in their course are at extremely high risk of death relative to people that were before that limb event. But the graph on the right is basically showing that also increases the risk for amputation. So. Okay, so then in terms of workup, so just summarizing again, right? So you've done an assessment, you've put a patient in a category, you've started them on appropriate medical therapy or double checked whether medical therapy needs to be, changed as part of your plan. Then again, what tests or what thinking needs to be done to define and further, zero in on, what the issue is to further describe it. So the advice here is basically to try to define an anatomic distribution of what the problem is and to start thinking anatomically, right? So after the medical therapy, you're starting to then, hone in on whether, there's any surgical therapy that's appropriate or, even what it might be. And in order to fix, anatomic problems, you have to think anatomically. So in particular with arterial disease, there's often these broad groupings of anatomic distributions that help to drill down, on where the pathology is and then often dictate treatment in part. So there's patients that have an aortoiliac distribution of disease. These are classically, heavy lifelong smokers that have, again, plaque that builds up centrally and into the iliac distribution. There's femoropopliteal disease. So this is, again, often in smokers, this is the most common presentation for calf claudication. And then there's people that have, again, tibial disease or tibiopedal disease, and this is often your diabetics, renal failure patients. This is, again, small vessel disease. And I would just say that often in patients that have tissue loss or have some sort of ulcer, it's typically a marker that there's some sort of multi-level problem that's going on. Typically, claudication presents at a single level, or the bulk of disease is at a single level. Another thing that I think is underrated, but is worth pointing out and influences at least my decision-making algorithm, is what somebody's femoral pulse exam is. And this is kind of independent of the disease process, but the femoral pulse exam matters, right? Because the femoral pulse exam from an endo side tells you whether you have an access point. And then it also kind of is a clue as to whether there's something more central going on. So somebody that has an iliac occlusion or significant aortoiliac occlusive disease often will not have a femoral pulse. And if you were then trying to, access that to do an angiogram for diagnostic and potentially therapeutic reasons, you're going to run into trouble there. So basically, I would say if anybody who doesn't have a femoral pulse in general, those patients I favor getting a CTA on because it helps you to plan and size, and define, interventions on things that you won't be able to see as well, in essence. The other thing that often gets done, and then we'll get to this in a second too, is understanding what somebody's baseline ABI or ankle pressure is. And in particular, if people have wounds or if they have calcified vessels where you can't get a reliable ankle pressure, obtaining a toe pressure, to stratify how severe the disease is. Treadmill testing gets done in patients who have, who one can exercise, and two, you're suspicious that they have relatively normal arterial studies at rest, but perhaps could manifest disease with significant exercise. And that's often seen in patients that have significant stenoses, usually in the iliac distribution, where it's a problem of inflow after they exercise. And then lastly, I think thinking about, we'd be remiss if we didn't say, understanding what somebody's risk and general profile is going to be. And then in terms of if you're thinking about doing an angiogram, right, knowing their renal function and baseline. Okay, so that was a lot on claudication, and now we're segueing more into critical limb ischemia and the treatment of such. I would just say in general about intervening on claudication, that is elective. And again, that's centered around lifestyle, and response to exercise and ongoing discussions, with a patient about, whether something can make them better. And that really comes down again to risks versus benefits. And there's a lot of complexity there, but critical limb ischemia is a lot less elective. So medical therapy still applies. So all the stuff that was said for claudication is still true, except these patients can't exercise because they either can't bear weight on a wound that they have, or they have such poor blood flow that they aren't really getting around very well. So instead, having a better sense for, again, what their baseline functional status, what they actually do in life, whether they live independently, whether they, require help for a lot of their activities, that milieu and that history becomes important. And again, in terms of, how this is a less elective, subset of patients, right? You don't have the same leeway that you do with claudication, where you may wait for them to quit smoking or to lower their A1C or modify their other risk factors. These patients often have, a wound that if you don't do anything about, if you don't get it blood flow, it's not going to get better. Okay, so then just a couple of surgical tenets that are important in terms of treating the different manifestations of critical limb ischemia. And these are, good ones to keep in your mind. So if you're talking about rest pain, the rest pain presentation, the surgical dictum is really to get direct inline flow to the level of their profunda artery. So the profunda artery is the deep artery that supplies the, the muscle of the thigh and then collateralizes down the rest of the leg. And typically, if somebody presents with rest pain, if you can get them enough inflow to that level, it will often resolve the rest pain. So that's often, kind of what's being looked for, or the hint there. In patients that have tissue loss, regardless of what type it is and that sort of thing, again, this is something that, you're going to think about in a very personalized, individualized, manner. But the end surgical point is often to try to get inline flow to the wound. So, if you can get unobstructed blood flow to where that wound bed is all the way down, and solve whatever occlusive processes are along the way, you will have done everything that you can, at least on your end, to get them to heal the wound. Okay, so then I wanted to talk about something called the Wi-Fi classification. This is, again, potentially more for the senior chiefly level residents. This is, I think, a very creative, so this is nothing you'll ever memorize, but this is a very nice way of how to conceptualize the complexity that goes into thinking about critical limb ischemia patients as well as their outcomes. So the Wi-Fi classification involves kind of three main things. So one, a description of the wound, and the severity and extent of, ulceration and tissue losses there. Two, a categorization of the degree of ischemia, broken down by, either ankle pressure or toe pressure. And then lastly, the presence or absence of foot infection and the extent of the foot infection, present. And then, so what they did with this, which is kind of nifty, is they basically combined these things into a matrix where they said, okay, if you've got, this degree of ischemia, either, 0, 1, 2, 3, combined with this amount of wound and, this degree of foot infection, what are the risk of amputation at 1 year? And then similarly, if you were to revascularize people in these categories, how does it change from one color to another? And then if you look, basically the stage, then the amputation risk by stage, right? So patients who were showing up red on, that matrix have a 50% chance of amputation at 1 year versus these lower stages have lower amounts. Stage 3 is closer to 25%, stage 2, just under 10%, and then stage 1, relatively low amputation risk. And again, so it's not that you have to come with this matrix and say, I have somebody with foot infection 1, ischemia 2, wound 1, arterial ulceration, their risk is this. That's really not the point. But it's, at least understanding where somebody lies on a continuum of ischemia, where somebody lies on a extent of, or amount of tissue loss, and then whether or not there's infection present, are things that are then factored into, the outcome and things that portend potentially, limb loss for these patients. And I think capturing that or being able to understand that is important. This is also another thing that's presented in that paper, which I have found very helpful at summarizing, essentially what are the thresholds for good non-invasive measurements on these patients, and what are we looking at as a barometer for where we would say that somebody is likely to heal a wound. Because I think often we order these studies and we say, okay, well, they're either totally normal or they're not normal. But the nuance of, okay, well, where's the inflection point and where somebody becomes likely to heal is kind of contained in this graph. So broken down. So TCPO2, which we have that capability to do that through the hyperbarics folks here. They will do that for us. And sometimes if the other non-invasive studies are either inconclusive or there's an unclear picture, sometimes having these guys do direct measurements around where a wound is very helpful. And the classic number there for good healing is 40. The toe pressure measurement is typically a little bit higher. Here it says 55. I would say you can see basically even at 50 or so, you're up near, again, 90%, 9 out of 10. But frankly, a toe pressure that is starting to plummet below, 40, is at risk for non-healing. And then in terms of an ankle pressure, if that's all you have, somebody with an ankle pressure of 100 should heal for sure based on this graph, right? But somebody that's in the zone of 70 or so, say, is a much more 50-50 shot. So I think having some of these numbers in mind, right? TCPO2 of 40 is a good number to have. Toe pressure of 50 or 55, is another one. And again, these are absolute pressures. These are not the, the ratios. So. Okay, so then I wanted to summarize everything that I do surgically into one slide for PAD in the spirit of the oversimplification of this lecture. So this is everything we do. But again, the point of this is more to say that if you're then taking all of this that you have distilled in an assessment and plan for these patients, and then you're trying to match it with a therapy, there's a relatively, simple set of therapies that exist. It's just, again, the nuance or the details between them or how they're conducted that really matter, right? But again, so there's, again, open surgery, there's now endovascular surgery, there's hybrid surgery, which involves some combination of the two. Deep venous arterialization is a random surgery that we've done a couple of times and that we're hoping in the end might help certain patients with no options. And then there's amputations, kind of like we talked about, as a primary therapy for people that are debilitated. It's not appropriate to heal their wound based on how far up a classification they are. A lot of foot infection, large wound, a lot of ischemia, etc. Okay. So yeah, and then this is stuff that was pulled out of arteries here at BAMC since the start. Does everybody understand the surgical terms? So thrombectomy or embolectomy is removal of clot or thrombus that's causing a blockage. Endarterectomy is removal of plaque, including the intima and media, with leaving the adventitia of an artery, and then often, reconstructing it either with some sort of autogenous, vein patch or a bovine pericardial patch or some sort. And then bypass is either replacing that segment or going around it, depending on the pathology. And then I'll say it on the next slide, but bypasses basically need an inflow artery, an outflow artery, and then there has to be a conduit between the two, right? For endovascular, so the three main things that get done, right? Stents get put in, angioplasty gets performed. So angioplasty is basically putting a balloon in the area, inflating it and deflating it and taking it out. There's different types of special balloons and different things. One of the ones that's, a little bit more in vogue now is to start to use lithotripsy balloons even to break up calcium and blockages that are within the walls of arteries. And then there's atherectomy, or basically like shaving or debulking or lasering away layers of plaque to create space to be able to then, do the other treatments to stretch the vessel. So, this again is another classification scheme kind of for the more senior, chiefly level residents to think about the extent to which occlusive pathology exists and the severity of it. This is called the task classification. Again, all the details here are very small, but basically it's broken down increasingly by location of where these exist, length of where they exist, and the pattern sometimes of multiple tandem lesions that are in place. And the thing, while it's not a direct, dictum, basically the more complex a lesion that is there, the harder it becomes to treat that person through endovascular means, and the higher likelihood, and sometimes, depending on the scenario, the more appropriate some sort of open reconstruction becomes. So again, there's classifications out there for this when you're thinking anatomically, about, again, exactly what you're dealing with. Okay, so just heading toward the end here and wrapping up. So in terms of this decision-making, once you're at the point of finally thinking about surgery, classifying lesions into their anatomic distribution, understanding a few of the dictums. So one thing in classifying things anatomically, I would just say, almost by default, something that's at the groin level, at the common femoral level, almost always gets treated through an open means. And that is because that's an area that's particularly prone in somebody that ambulates to a lot of flexion, and will crush any sort of stent or something that's there. It's also very accessible by being superficial and that sort of thing, to again, perform endarterectomy or replace that segment of artery however is necessary. We talked about on the previous slide how complex the pathology is, then sometimes increases the likelihood or need for open revascularization. Some other things just to think about, right? So from the endovascular side, the things that matter in planning that come down to what is the access point going to be. So that's why we mentioned earlier femoral pulse exam. And then what's the approach going to be? How are you going to get there from your access point? And these are kind of often the themes of what we're talking about when we're doing, some sort of endo intervention, is how to you know, if the technology that we need to get there is a balloon, it's a stent, whatever it is, the ability to actually reach that point, to know that we're at the point that we should be, you know, to double check, you know, those things before doing the intervention are kind of the, again, the thinking or decision making that goes into it. In open surgery, right, it's always proximal and distal control. You guys hear that, you know, in multiple areas, but that's no less important for any of this. And then in particular, like we talked about with bypass on the previous slide, understanding what the inflow artery is, the outflow artery, and a conduit, and those have to be suitable for any, you know, kind of given intervention. The last thing I'll say, and it's kind of alluded to, but it's just, you know, kind of in my mind, one of the big take-home points, especially with critical limb ischemia patients, is you have to really understand and think about, this is where the doctoring comes in, you know, what is the treatment goal for these patients? So, you know, are you just trying to heal a wound that's present? Are you trying to get them out of rest pain? Are you trying to get them to return to work, be a more functional member of society? You know, whatever it is, and kind of drilling down into that, because, you know, what you have in mind for that is going to dictate, again, how aggressive you are, how much risk you're willing to take on, you know, and to what extent you want to intervene, right? Because, you know, often these patients can have quite a bit that's there, but the selection of what you actually ultimately do and how you balance the risk, I think, comes down to what the bigger picture goals are, right? And this again, when we talked about rest pain, right? The bigger picture goal might be, I want them to get out of rest pain, therefore I'm going to do an operation that gets the profunda open. If the goal is to, you know, get them to heal the wound, I need them to get inline flow to the wound, I'm going to plan an operation, you know, that gets them inline flow to the wound. And, you know, lastly, often, right, and as mentioned about as a marker for big systemic disease, you know, it shouldn't be lost that the physiologic stress of any given operation can be significant. It has to be taken into context with, you know, the plan as well. And then in the end, right, it doesn't just stop with the operation, right? But often, sometimes, especially in critical limb ischemia, there's a period that you need for the wound to heal. They often need to be off the wound and prevent, you know, pressure and tension from going on it in order for it to heal. There's often, again, rehab involved in that sort of thing. And that also factors into if the plan is for amputation, in terms of what amputation are you going to do? You know, what's the rehab look like for that? What's their functional status and potential to rehab? You know, all those things kind of come together here in an important way. Okay, so to recap, again, this was perhaps, you know, not a ton about surgery. Surgery was summarized on a slide or two, but was a lot about thinking about the different ways that these consults get funneled, how to categorize them, and, you know, after you do categorize them and you capture what the acuity is, how to then jump off into the management, right? So don't forget about risk factor modification, about medical management. Those things are always, you know, a universal thing and should be done first. It's amazing. We get a lot of calls, right? And you guys are pretty good about it. Like, you know, where the person's in the emergency room, they're not on aspirin, they're not on a statin or something. And if nothing else, if we're going to tell them to follow up in clinic, we should also be telling them to start, you know, the indicated medical therapy. And then, yeah, we talked a lot about, again, what the goals are, stratifying risks. And then in terms of surgery, you know, again, thinking anatomically for any intervention and what these anatomic categories are here can help to break down and simplify a given presentation. So forgive me for any errors in the slides or whatever. I was doing this with my kids yesterday, so but I can take questions. I also have like a few random pages within the last couple of weeks that we've gotten that I could go through, or we could take a long break, whatever you guys want to do.